mode.
Good afternoon, everyone, and welcome to another Learning Lunch hosted by FormatApproved.com and generously sponsored by Athena Health, a leading provider of cloud-based EHR, practice management, and care coordination solutions. As a benefit of their sponsorship today, Athena Health has also provided a free white paper on this important industry topic for all of our attendees entitled ICD-10, Preparing Your Practice for the Big Changeover. That white paper link will be available at the end of this presentation and will also be delivered to all attendees in our follow-up email to you. My name is Wendy Whitmore. I'm the CIO for the Formed Corporation, sitting in today for the always entertaining Brian Johnson, our Senior Director of Online Training, and hopefully, I'll be able to fill his talented shoes as moderator for today's session. It's been a while since I've done one of these. Our title today is Tools for Transition to ICD-10. We're joined today by Lynn Kuehn. Lynn is president of Kuehn Consulting, LLC, specializing coding services for all settings. Lynn provides training to small and large groups on ICD-9, ICD-10, and other HIM-related topics. She has served on the AHIMA Board of Directors and has authored many of AHIMA's most popular coding books. We are very pleased to have Lynn with us to discuss this important industry topic today. Welcome, Lynn.
Hi.
Hey. Before we begin, some quick notes for our attendees. If you have questions during this session, please enter them into the chat area on your screen. In the second half of our presentation, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link as well. Also note that all registered attendees of today's Learning Lunch will receive an email with a link to a brief session survey, which when submitted will provide immediate access to the recorded and PDF versions of this event. So let's get started. Hi Lynn, welcome, thanks for joining us.
Hi Wendy.
Hey. Obviously, ICD-10 has become an extremely hot topic. There are some deadlines looming, people are confused about what it means and why it is being implemented in the first place, and there have been a lot of rumors about it starting, not starting, etc. And so what we've noticed as we start to outreach to our Format Approved audiences, we get a lot of questions through the website and through our 800 number, etc., on this topic. So as a result, we've done a couple of things. We have, obviously, we've invited you, a renowned industry expert, to talk to us about it in this webinar today. We've also engaged in a partnership with Libman Education in order to mount a new ICD-10 training course for coders to help them bridge that knowledge gap between ICD-9 and ICD-10, so we'll talk about that at some point. And Lynn, you have an affiliation with Libman, so obviously we are focused on bringing the most knowledgeable ICD-10 professionals into this conversation with us, and so we're going to do that a little bit today. So let's start first by asking, let's go back a little bit so we make sure that our audience fully understands what ICD-10 is, when it's going to start. Let's just give all of us a little baseline.
Okay, great. The ICD-10 system is actually called the International Classification of Diseases, 10th revision. And the United States is going to be using the clinical modification of that, or ICD-10-CM. And that describes diagnoses, and then there's also a procedure piece to it, ICD-10-PCS, or procedure coding system. That system will be used to describe hospital procedures. And both of these systems, both pieces of this, will replace the old 9th version on October 1st, 2014. So this is a classification system. It's a way to categorize diseases and procedures so that we can use the data later on. We can then use that to retrieve data for research, for decision making, and here in the U.S., not other parts of the world, but here in the U.S., we use these systems to group patients together for reimbursement so that we get paid. Various different reimbursement systems in our healthcare environment are paid on using different pieces of this. This system that we have now was implemented in 1979, the 9th version, and that 9th revision is antiquated. That system has not been really changed in its structure since 1979, and I'm pretty sure everybody understands that healthcare isn't like it was in 1979.
No, my goodness.
We can't capture.
That's an
yeah,
awful
that's an
long time
understatement,
ago.
don't you think?
Yeah.
Yeah, it is.
Goodness.
And things have changed. Just think about what it was like. I was in the hospital in 1972 to get my tonsils out, and my statement my parents received, I happened to have it, was typed with a typewriter. There was evidently no computerized statement system. And so that was only 7 years after that, that the current diagnosis and procedure system that we use in hospitals and in all of healthcare now was implemented. Think how old that is. We can't capture the details that are, the details that are really important to patient care many times are lost with this old thing. And so we have to overhaul the system. And we're going to have all of that happen on 10/1 of 2014. We're going to then be able to code all the details that we need to and be able to classify new technologies and new diseases, things that we haven't been able to incorporate into that old system.
Well, it
I
makes
also
sense.
should mention.
Sorry, I just wanted to interrupt real quickly. It does make sense that at some point they would make a modification. I can't think of a single other thing off the top of my head in healthcare technology that is still in existence from 1979. But assuming, that we were operating with other, obviously up until recently, some folks were still working with paper records as opposed to electronic health records as well. But it kind of falls in line with that, that lag, I guess.
Sure, it does. And, the hard part about this is that the system was originally developed for that paper world. And we need a system that will work with electronic systems. The system that we have now does not even have a full code title for each code. And because of that, it's very hard for programmers to do data searches on it. They can use the code, but sometimes they want to actually search for full words and concepts in the codes, and it's just not there because it wasn't developed for the electronic world. Think about 1979, we didn't even have personal computers on our desks. Many hospitals and certainly physician offices did not have their own computer systems. They bought time on a big computer somewhere. And so this system is so old, it just doesn't do what we need it to do. And then we have to also take into account that we're behind the rest of the world. This ICD-10 system is international. So much of the rest of the world went to ICD-10, the international version, in 1990. We participate in the World Health Organization, the people that manage ICD-10 International. And so we've had to code in the new system to submit our international mortality data for the last, what is that, 24 years?
Yeah, a long time.
So we're really far behind. And so it's just time for the overhaul.
That makes sense. Is the CPT going to be involved in this change?
No, there are going to be no changes to CPT. CPT is used for different things. It's not used for diagnosis coding. It's really a nomenclature that describes physician services. It's a naming convention. That's what a nomenclature is. But it does such a great job of naming physician procedures, surgeries, the work that happens in the outpatient setting that it's been adopted as the computerized language for describing physician services, hospital outpatient procedures, lab, x-ray, therapies, other kinds of services that are not hospital inpatient procedures. And so that is not involved in any of this. And so physicians don't need to worry about changing their procedure codes, and their payment system in the U.S. is based on that. So that payment system piece for the physician environment is not changing at all. And that's because CPT does such a good job of describing physician services.
Well, that's a good piece of news. I mean, I think one of the pushback comments that I hear quite a bit coming out of the medical community in particular, and you know, the level of concern around this topic, and the reason it is such a hot topic right now, is that there is a lot of confusion, and I think people are not quite sure, you know, which pieces and parts they're going to be responsible for from a clinical standpoint. Certainly the coders and billers, I think, are probably a little bit, you know, a little bit more up to speed on what's going to be expected of them. But from a clinical standpoint, I think there's a lot of rumor and confusion. And so I think it's helpful to answer questions like this, you know, knowing that CPT is not going to change probably helps people feel a little less stressed out about this topic in general.
That's true. That's true.
So who's going to be using these new systems on the CM and the PCS side?
Okay. ICD-10 CM is the diagnosis coding system that's going to be used by the entire healthcare system. And that's because we need diagnosis data from all of the healthcare providers that are out there. That is the consistency across the system. Everybody's going to report their diagnoses that way. But I did mention that there is a procedure coding system that go with this, and I think that's sometimes where that confusion comes in, Wendy, that people aren't sure what is this new procedure coding system. Well, that's only going to be used for coding and reporting hospital inpatient procedures, and it's reported only by the hospital. So it goes on the hospital claim to describe procedures that are performed during an inpatient stay. So as I said before, physicians are still going to code and report in CPT for the surgery that they do, for their professional work, but the hospital is going to report what happened in the OR with these new procedure codes.
That makes sense.
And yeah, and that's the division there. Professional coding and those services performed by the physician, the surgery itself, uses CPT, but the use of the OR, the provision of the devices that might be placed into the patient, like a new hip or a cardiac stent, those things are going to be described with this new PCS system. And that's the difference between the two. One describes the professional work, and the other describes the use of the OR and the provision of supplies. Okay.
Got it.
And so the basis for that, let me just finish this up. The basis for who uses what, so just so everybody knows, is this is based on HIPAA, the Health Insurance Portability and Accountability Act. There's a portion of that act that literally has in law what code sets and what computer transaction sets have to be used by different providers. And the HIPAA-covered entities, people covered by that act, the healthcare providers, have to follow those rules, and so that is the basis for all of this change, just so that everybody knows.
Thank you for that. That does help clarify. You know, it's interesting. I have heard quite a bit of debate about the ICD-10. Should we put this on the shelf and instead go to ICD-11? Should there be, you know, should we be looking at a more holistic transition further down the road? From your perspective, knowing what you know about ICD-10, what are the benefits for the clinical community?
Well, let me ease into that. As I mentioned earlier, you know, the system has to be overhauled. We mentioned just how different healthcare is now than it was in 1979. Even though we've been updating this system every year, because we do get updates for every October 1st, the framework of it really hasn't moved forward. And you can't really describe cutting-edge medicine with this old system. It just doesn't work. Let me try to give you an analogy here that might help you. It's kind of like trying to drive a car that was built in 1979 that was not built for fuel economy and not meant to be nice to the environment, not meant to be green at all. You could even paint that car. My 1979 Cutlass didn't have a cup holder. I could even put a new engine in that car, but I'm never going to make that thing into a hybrid. It's never going to be 55 miles to the gallon. It's never going to be nice to the environment. I'm going to have to sell that old car, and I'm going to have to buy like a Chevy Volt or a Focus Hybrid or Prius in order to get that kind of technology built in to that car. And healthcare is really kind of that same way. The data system that we've got to use wasn't built around today's terminology and today's technology for the medicine. The system has not kept up, and you just can't, by adding something to it, fix it. It has to be built in, and the framework has to be changed. So I would say that the immediate benefit for the clinician is that they're going to be able to support the services with better diagnosis codes that describe what they're trying to say in medicine. It's going to show the patient's severity better with the new codes to support evaluation and management codes, to support why a patient would need a surgery or why they needed a particular medicine. So let's take an example this time. Let's look at asthma. In our current system, we have words for asthma like intrinsic and extrinsic. Those are very old words that don't really describe how we think about asthma in today's medicine. We can, in the ICD-9 system, actually say that the patient has an acute exacerbation, or they have what's called status asthmaticus, that they cannot control that asthma attack. But other than that, we can't describe asthma the way the pulmonary people, the allergy and immunology people talk about asthma today. In the new system, it's going to follow the NIH recommendations where it talks about intermittent asthma or persistent asthma. Two different kinds, different words, different concepts from the old system. Then it also says, is the patient a patient who has mild, moderate, or severe symptoms that cause them to have problems in their daily life. Then in each of those individual categories, you can still say whether they have acute exacerbation or they have status asthmaticus. So that was a kind of a complex example, but what this does is it shows the clinician that the system works with the terms they use now. So they can say then that their patient is sicker, and they also can, in their practice, figure out what is their patient population. Do they have to work harder at managing their asthma patients? Would there be a certain educational program that they might want to offer to just those patients who have moderate or severe persistent asthma, maybe not the other ones? They also might be candidates for a new technology procedure, like a bronchial thermoplasty. And you can tell the insurance company, this patient needs that because they are much sicker, rather than to have to write a letter or to do something like that. This coded data is going to describe this patient as a patient who has much more severe illness. And that's just one example in the new coding system how it works better in today's technology, in today's terminology.
So it's better terminology and better and higher level of accuracy, would you say?
Oh, yes, yeah. Because right now all we can say is the patient has intrinsic or extrinsic asthma, and if they are not in an acute exacerbation, there's nothing we can tell the insurance company or the or another provider, an educator or whatever, that says that they basically, one patient is sicker than the other on an average day. So the system is built now to go more towards the clinical language.
That's good. That seems like an improvement.
It is. And so that's a short-term benefit. that we're going to gain right away with the new codes. Then in the long term, we've got other benefits that are different. We have Medicare Advantage plans that actually design their yearly payment schemes off of how sick the population is that's served. So when you have the better ability to show how severely ill the patient is, you have a better chance for higher reimbursement. And then, in addition to that, all of the data that we develop in healthcare gets de-identified and sent off to the CDC for public health. It gets sent blinded, de-identified to pharmaceutical companies, to device researchers. So they design new medications, new products, all kinds of things based on this for the future. And I can't even tell you all the places that this de-identified data goes, but that is how we get these breakthroughs in diagnoses, breakthroughs in new treatments, technologies, all kinds of things. That forms the basis for clinical trials and all those kinds of things. That's a long-term benefit that this new organization of data can help us. Not just asthma, but hypertension, diabetes, myocardial infarctions. It tells, we're able to tell exactly which coronary artery caused the heart attack. So the reorganization is going to help the researchers connect the dots. So
I think that that sounds like an improvement. I do know that, and I think we'll address this in a little bit, but I do know that one of the concerns from a clinical standpoint has been how it does affect or how it will affect their insurance payments. And so I'm sure we'll touch on that. But I realized that as you were referencing that component as it being more accurate as it relates to the reimbursement side, I think that's been one of the concerns from a clinical standpoint.
True.
On the document, speaking of clinicians, on the documentation side, how's that going to change?
Well, there is no doubt that it is all about documentation. The provider documentation starts everything in healthcare. It is the communication piece, and it is also what the coded data is based on. So we can't get away without talking about the documentation. The ICD-10 system is designed to capture details, and the right details, not just more documentation. We don't want the provider to have to dictate or get more information that isn't necessary. We're just looking for the right details at the right time. So we need things like laterality. Is it a left, a right, or a bilateral condition, or is the procedure on the left or the right side? And that seems pretty simple, but when the patient comes back for follow-up, sometimes those details can be lost. All it'll say in the documentation is hip fracture. And into the future, we're going to still want to know, was it a left one or a right one that was broken? And so there's also documentation that's needed to link complications to specific disease processes that cause them. And in the area of obstetrics, we want to know the trimester of the gestation and actually the number of weeks of gestation when a complication occurred. Those are the kinds of things that really are help perfecting the prenatal care in this country. So we do need those pieces of documentation, and that's really what it's all about. So the challenge is to know what to document. We really don't want to send providers out there blindly and having them just create lots more documentation. It's about hitting the target. Templates can help with this. Having a short list of details by physician specialty can help, because that just keeps it keeps us on track to try to get the right stuff for the right diagnoses. I have been working on this problem of documentation for quite some time, and I've created some quick reference lists that are for the major specialties in healthcare. There's about 16 specialties that really submit more than 90% of the charges off to insurers in this country. So I settled on those. And I compared the ICD-9 CM diagnosis system to the ICD-10 CM diagnosis set, and I went category by category, literally looking at the code book side by side, so that I have a pretty good list of what we need to document. I can't say in only 1 or 2 sheets of paper what the exact words are, but I've got it nailed down to quite a few of the major themes, the important words by disease process. And so I think that on every piece of training that I develop, I try to incorporate those in, whether it's face-to-face, whether it's an online through Libman, whether it is an audio like this. I try to make sure that physicians understand that this is specialty specific. And so by knowing the key words or the themes that are involved in the diagnosis code selection, you can get those details into the documentation and have less to learn by specialty. Because without that specific documentation, we can't really code. And without the codes, you can't analyze, we can't use that data for planning and all kinds of things. And so the physician documentation is really the basis for it all. Public health and safety and all kinds of different things. And the documentation is the key piece. It is a classification system so that even if we didn't have great documentation, we still have a place to put things. The unspecified codes are not going away. That's really important to mention. There's been a lot of rumors out there about that unspecified codes would be going away, wouldn't be paid. That is not true. Not true at all. The unspecified codes are there because in a classification system, we have to have a place to put everything, and there are many times when we just don't have more detail on a specific disease process, and you need to code it in an unspecified code. And even CMS has come out recently and said unspecified codes are not targeted in any way for lesser or non-reimbursement. So the documentation, whatever we receive for documentation can be coded. The goal is to just get the specifics from the physician's brain into the documentation so that it can get into the codes and be used then throughout healthcare. We're trying to tell the patient's best clinical story with these codes.
Would you say that although the unspecified codes are not going away, which is probably a helpful answer for a lot of people, there will be, would you suggest, based on what we understand about ICD-10 having more codes available, that there would be less use of the unspecified codes?
Yes, we'd hope so. We would really hope that if the clinicians give us the details, and we're trying to help physicians up front to know what is important information that they may know and didn't think we needed to know on paper before. We think that as we get those right details, we are then going to be able to now have a place to put all those things so that we can communicate in coded form these details that are important. And because there are far more specified places to put things, we hope to find a place in the coding system correctly for all the documentation. And you're right, have less use of unspecified codes.
Well, that makes sense. I would guess that's one of the goals of the transition. Yes.
Mm-hmm.
On the hospital side, what's going to change in that procedure coding? How is that going to affect the surgeons and the surgical specialties?
Well, my first bullet here, just so everybody understands, even if they may have joined us late, CPT is still being used for coding professional services. What's changing is on the hospital side, that the hospital is now going to have a better system to describe what goes on in the OR, what kinds of tools are used, and what kind of devices would be left inside the patient when they leave the operating room. So this hospital system is much older than CPT. It was developed in 1979 and has not gone through as many updates as CPT has. It has only 4 characters to the code, or 4 digits now, and so you have a limited number of codes, and the hospitals have such new technology that they need to describe that they needed a new system. So the government actually asked a system to be built specifically for this, for the new technologies. It's a 7-character system that describes what goes on in the OR. And so part of that new development was to say, how big does code need to be? It's got to be 7 characters so that we never run out of characters again. And they made it so that each character had meaning. And they designed it based on what's called root operations, or the intent of the procedure. What is my root, the basis of all of the procedure? And it has new terminology that's used, and it attempts to classify similar types of procedures using this root operation word. It has specific definitions for each of these words, which we don't have in our current system, which makes that system very difficult to classify in. And it is going to be a learning process for the coders of the country to learn how this system works. The other thing is that I just mentioned that all the physician documentation is the basis for all coding that goes on. And so one of the reasons we're going to talk about these hospital procedures a little bit today is because the hospital coder can't describe what went on in the OR if those details aren't there. And so even though the physician is not going to code this for themselves, their documentation still has to support these codes.
So that's interesting. So one of the important bullets there was that the physician coding is the basis, and so again, one of the common questions that we get here through Format Approved is what the expectations will be of what the physicians or clinicians need to know about the ICD-10 versus ICD-9 codes. So before we jump into the next question, maybe just a little comment regarding that component. Obviously, the coders and billers need to understand this at a very high level. From a clinical standpoint, if that documentation is primary to both their operations as well as any transition to the hospital for the patient, what is going to be expected from a physician standpoint, practitioner standpoint?
Well, their documentation is going to be very similar to what they have to do for documentation to support their CPT code, but sometimes the two systems use the same word in different ways. And so the coder is going to have to be able to do a translation between the two of these systems. And I guess the biggest difference is that the physicians don't have to use that new terminology. They just need to be creating the documentation that supports their codes, and sometimes it might be an additional word or phrase or some information, more information about the device. CPT doesn't always care about, if you put in a cardiac stent, it doesn't differentiate between a bare metal stent and a drug-eluting stent or a radioactive stent. But because the hospital has to describe and then be able to get reimbursed for the exact devices that go in, there's just a few more details on some things like that that are going to have to be documented. We're going to have some ways to capture that, but really the operative report from the physician is the basis of it all. Okay?
Yeah, that makes sense. And so looking at the root operations and what you were just describing regarding how it relates to the CPT, you're basically answering that same question, but what is, are the providers going to need to translate? So for instance, if the CPT doesn't recognize those different stents, how are they going to get that information collected, as it were, for their documentation?
Well, what we're hoping is that by specialty, we're going to try to have everybody working together. Coders, some people that I'm going to talk about in a little bit called clinical documentation improvement specialists, and the providers working together to try to understand what kind of documentation improves healthcare in general, supports CPT codes, and also supports these new procedure codes. And one of the reasons we're talking about it today is that when the rules change, it's only fair to tell people ahead of time what the rules are. And so I think we ought to be working with teams of people like that ahead of time. And it is only fair to say that the root operation terminology, although the physicians are not required to document it, the coders do have to be able to interpret it. And it describes things sometimes in the same words as CPT and sometimes not. Destruction is the same thing, the same word in CPT when we destroy a skin lesion versus in CPT it's the same thing as destroying something in PCS. But the words are not always the same. I don't think the word extirpation is found in CPT, but in PCS that is an old word that sort of got resurrected. That means taking out solid matter. So taking out a calculus, taking out a foreign body like a bullet. Those kinds of things, the coder is going to have to be that go-between, going to have to be the translator. And many times it's the same concept, but it's different words. Like CPT refers to something as an arthrodesis when a joint is fused, and PCS specifically calls it fusion. And so there's that translation problem that's got to happen. And if you think about it, it's sort of like dialects of languages. There's for Spanish, there's Latin American Spanish and there's European Spanish. They are similar, but yet different enough to cause a little difficulty if you don't exactly know what the dialect is. So you sometimes need a translator, and the coder and the clinical documentation improvement specialist may be the translator between to make sure that this all works. The coders are working really hard. They're responsible for learning all this new terminology, and we're trying to help providers to know what to document so that everybody can work together. And so let me see what else I need to tell you here on root operations.
That last bullet on because obviously we made a point of commenting that they were not going to lose the unspecified codes in on the CM side. I noticed in your last bullet that you're saying the opposite about the PCS side.
Yes, and you know that's probably the hardest part of the whole system is if the documentation is missing, that the coder cannot interpret it, cannot find it anywhere else, the only source the coder is going to have is to do that query process. So it's send the question to the physician because there are no unspecified characters or full codes in PCS. We're stuck. So that entire hospital bill, which as you know is a large dollar amount, will be held back until we can determine what that procedure code is for the hospital side.
What do you think? What do you think the reason for that was? I mean, it does seem to me that from time to time there would be, particularly as you mentioned, in a very large bill like that, there would be a situation where they might not be able to identify something specific in that bill. Is the intent to make sure that it's 100% accurate? And is there a high likelihood that the PCS codes really do contain absolutely everything?
Well, they were trying to make it be as specific as possible. We've lived for a long time with the hospital codes being very muddy. You having to classify things together that really don't belong together. And I think they were trying very hard to make these codes mutually exclusive so that you didn't have, for research, things bundled together that don't belong bundled together. Mm-hmm. We do have one root operation called repair, which we are allowed to use if the actual operation doesn't fit anywhere else. So there is the one fallback position, but there really aren't any fallback positions when we aren't able to determine from physician documentation how they got at the body part, such as was it an open procedure or was it through the skin using the scope, things like that. There are 7 of those options and you have to pick one. And the devices, sometimes you have an option called other device because there might be a new device that's yet unlabeled. But sometimes you are forced to make a choice. And yes, it will provide great clinical data, but it may slow things down until we really learn what has to be documented and we get cooperation from everyone, or we find a source for that via the a surgical log or something like that. So I think their intent was good. We just have to figure out how to operationalize it.
Well, that should be an interesting component of the transition, I would guess, is that limited ability to make alterations. Obviously, that said, with the opportunity to be able to apply other and distinguish, that obviously leaves room for some new technologies, which was my question as you were saying that. That, obviously, if you're not going to change codes from 1979 to now, and then at this point you're going to say these codes are absolutely fixed, then you've got to assume that no new technologies are going to surface during the term of the ICD-10 PCS code set. But what you're saying is that they did leave some flexibility in that regard.
Well, let me say, Wendy, though, that it's not that the system is a closed system. We'll be able to get updates every year, and with 34 possible options in every one of the 7 positions, we have the ability to grow those codes, but we only get updates to each character once a year. So I don't want to give you the impression that it is a stagnant system. It can be updated, but like the current system, we only get an update every year.
Right, and there, with the speed at which healthcare technology is moving right now, my immediate question, as you were saying that, was, well, what if somebody comes up with a new, fantastic, interesting technology? But there is room in there to make those adjustments to a certain degree. Right,
but when we get an update the following year, yes. The most you'd have to ever limp along is 1 year.
Right. But in that case, as you mentioned, there are some provisions for that where they've said you can choose other technology.
Right.
This is the question we get most frequently, quite frankly, and obviously, as it relates to ICD and CPT, largely clinicians are concerned about getting paid. So do you want to comment a little bit? Obviously, CPT not moving helps, but how else will their reimbursement be affected?
Right. The professional fee reimbursement comes through CPT, so that's not changing. The diagnosis codes are required, and so they're sort of like a permission slip. You need one in order to get paid, and you need a valid one, and I think that's the part that providers are concerned about. We are going to have CM codes that go from up to 7 characters now. 5 is the maximum currently, and it's going to go up to 7, and you do have to know the system enough to know what codes are valid and which ones aren't. So you need all of the characters in place. And computer systems really should be editing out those that aren't valid for the provider before it goes out. So a clearinghouse or even an internal EMR or a practice management system. With a valid CM code at this point, evaluation and management services should be paid. We will continue to have those LCDs and NCDs from the government that says that only certain diagnoses are allowable for certain procedures. Those are going to stay. But in general, I think on some of the things that get stopped for review by insurers, that they want specific information, the good detailed CM codes will speed reimbursement. It's not going to increase the amount of money, but it should make it go faster because it's not going to stop for review as often if you can explain it well with a good code. Hospitals are going to get paid the same way they have, based on a combination of diagnoses and procedure codes, and when they're supported by good clinical documentation, they're going to get the best possible reimbursement using the new codes. And so stay tuned. I think it's going to be fine as long as there is a valid diagnosis code on a physician claim. Things should pay fine, and good software will help to edit that for the provider.
And I think there are a number of tools, both plugins and components of electronic health records and things like that, that are going to help in this regard, certainly from what we've seen in the industry on the HAT side.
Right.
You did mention that you did not think that it would pay more. A lot of the questions we get are relevant to whether or not we feel like by detailing the codes at this much more, finite, or rather not finite, but this much more complicated level, is it going to pay less?
No, because especially on the physician side, the reimbursement is based on the CPT code. And I think that the codes will do a better job of saying why a provider might have listed a higher level E&M code rather than a lower one. And right now, that is paid at whatever the approved amount is for that code. It's always the after the fact, looking in an audit where it could be a challenge. But I still think that the codes are going to do a better job of supporting who's got a higher severity patient.
Good. Well, I'm glad you answered that. I do think that is probably, of all of the questions that we receive on a weekly basis on ICD, that is probably the one that we hear over and over again. Obviously, there's a lot of talk in the industry about reducing healthcare costs, right, and reducing the cost of procedures to patients and things like that, and all of that is worthwhile from a overall healthcare cost standpoint. Obviously, it does impact how clinicians view these changes. On the hospital side, the hospitals have their clinical documentation improvement specialists that you were mentioning. Can we talk about that a little bit? How is that going to
Sure.
How is that going to change the industry?
Well, we're seeing that more and more facilities are getting clinical documentation improvement programs with these specialists on staff. And I believe it is to form that team approach so that the clinical documentation or CDI staff can help the doctor know ahead of time, before the patient is discharged, what small piece might be missing that the provider needs to document. I like to kind of call them the just-in-time documentation helpers. They look at the clinical documentation. Many of these people have excellent clinical background, so when the clinical documentation isn't clear to them, the picture isn't clear with what they know will be coded, then they go back and ask the provider in real time, what about this? Could this be documented? And so that's going to help for research, the registries, all of the stuff where the data goes, plus the reimbursement for the hospital. But the physician should take note of when they get questions like that from the clinical documentation people, that's something that they also should be thinking about in their office. If it's important for the hospital record, that's the kinds of things, those details that they also should be documenting in their office records as well, because the CDI people wouldn't be asking those questions if they didn't need to know it. And there's a really important piece here that providers sometimes aren't aware of. Coders cannot assume anything. They are only allowed to code what the clinician has documented, and it's because the clinician has the license to do the diagnosis. That is what the medical license or provider license is for. And so the coders can only use what is documented when they assign their codes. And the CDI people are there to help get it documented so that the coder can code it.
So providing a translation. So providing a translation between what the physician might have been trying to say and didn't quite say accurately, and what the coder is attempting to interpret.
Right, getting that extra detail.
That makes sense. From a training standpoint, since we are a training group and you and I both belong to training organizations, what training do you think that on the clinician and the staff side, I'd like to back up just as one half step and say, how are they training those CDI people? I mean, what sorts of training will be required of each one of these aspects of the community, and what does that look like?
Most of the time we're seeing the CDI people training right alongside the coders as partners. They have the strong clinical background. Sometimes they're helping to teach the coders. The coders are helping to teach the CDI about the classification system. And then together that team works hopefully with the providers, the clinicians, to beef up the documentation and to get just those details that are needed. And so then as I bulleted here, the basic training that providers need to know is what's changing and when. And so just this webinar today has been a really great start to learning that CPT is not changing. It's the diagnosis that are changing for physicians, and it's the hospital side that has a procedure code change. And so then from there, I think the training should progress towards the specialty level. That you would not want to bother the cardiac surgeon about what the hip joint has to be documented as. You wouldn't want to bother orthopedics about those different devices for the cardiac stents. And so I think it's specialty specific, and good training would take it to that level. An individualized training with that team of coder, CDI, and provider as a team trying to work towards the best content possible.
Well,
physicians don't necessarily, excuse me, Wendy, physicians
okay.
don't need to know how to code. They, unless, of course, by their own choice they decide to code. What they need to know is how to document.
And that makes sense. We do have a few questions. It looks like we have about 10 minutes to do a little bit of breakout of a few of these questions, and any questions that are not answered toward the end of the session will be addressed via a post to our website and a link out to you as an attendee after the fact. One of the questions is, and actually I've heard this rumor numerous times about ICD-10 as well, will there be a period of time when both ICD-9 and ICD-10 are running concurrently or simultaneously?
Actually, no. Not in a live environment. Many pieces of training that you see do talk about something called dual coding, and they don't mean that after 10/1/2014. What they mean is using these systems in parallel before the go live to make sure that the IT plumbing, you know, how the data transfers is actually going to work ahead of time. So there's no grace period, no overlap in the live environment, but we are advocating doing coding ahead of time in ICD-10 on a certain number of cases to make sure that your system is going to work to send data on 10/1. So I did see something out in one of the things that came through my email today that some providers are asking for a grace period on diagnosis codes, saying, you know, we don't want to be penalized for getting them wrong in the first period of time. And again, it's not so much about getting it wrong, it's about getting it to be valid. All of the characters that you need in a valid code and describing the diagnoses in with the best possible code. So no overlap, no grace period as far as we know.
Another question is, thank you, I appreciate that, and I think that's been a very big miscommunication in the industry about ICD-10, is that I think a lot of people believe that there is going to be once that 2014 date hits, that there will be a transition period that involves some confusion and dual, side-by-side coding, and that everybody's going to need to learn how to map everything from here to there. So I thank you for that. One other question here is that de-identified data collection that you mentioned, that it will be improved through the ICD-10 coding. Will the physicians be at all responsible for any of that data transfer? I assume if it's all de-identified, is it an opt-in, opt-out, or how are the clinicians and practitioners going to be affected by that?
Well, in the physician office right now, there is no nationwide mandate to submit data. In some states, they are mandated to submit data. And so you don't have to opt in, have to opt out, anything like that. If you live in a state where you have to submit data, I would assume that you would already know about it at this point because it's been ongoing in ICD-9. The data that is collected in the de-identified mode mostly comes from insurers. And that's how healthcare data comes about now. That's how we know how many people are injured in a certain way and all that kind of thing. The hospitals do submit data to the CDC. They also submit data. I believe every state in the country has hospital reporting requirements, and so many times we have far better data from inpatient stays from hospitals than we do from the physician side. There is currently, as far as I know, no plan to require physicians to submit on a nationwide a plan like that. However, Medicare does collect all the data that we send in, and that is a major source of data on the adult population.
Great, thank you. We have a couple of other questions that are relatively specific. If you have a quick answer, we have just a couple of minutes. Somebody's asking if the CMS issued guidance, Medicare claims processing for ambulances and ambulance trip coding. Are you aware at all of how CMS is going to move forward and provide an updated listing of those types of codes?
No. I do know that CMS is currently working on all of the NCDs and LCDs to translate them for ICD-10 codes, but I don't have anything specific on for unique providers, such as ambulance. I really don't have anything on that.
All right, well, maybe that's something we can do a quick bit of research on after and shoot out with our summary of answers to some of these additional questions. One of the other questions, which is interesting, is there a workshop or webinar, and I swear I'm not doing this, I'm not adding this in on purpose, or falsely, this is actually, somebody asked this at the moment that I'm loading up the fact that Lynn Kuehn and Gail Smith from Libman Education will be presenting a live training event on bridging to ICD-10. If you want to learn more about that, you can go to libmaneducation.com. This link will also come to you along with a whole bunch of other links in a follow-up email following this event. And we are pretty much run out of time, Lynn, so I want to thank you profusely for joining us today. Obviously, this is a very important topic, and the reason I know it is not only because we had so many people registered for this event, but our audience attention span for this event was at a well above 95% during the entire session. So obviously you did a great job of keeping everybody's attention, but we also recognize here at Format Approved that ICD-10 is a topic of both confusion and concern, and so we're going to continue to provide as much education on this topic as possible. Toward that effort, we have created, in conjunction with and in partnership with Libman Education, we have rolled out a bridge training from ICD-9 to ICD-10, largely for the coding community, and that is currently available. It has become available in our storefront at formedtraining.com. You can receive a 20% discount on that course if you are a coder or biller or have one in your practice or a practice manager. Through our partnership with Libmin, and that link will come to you. It is also on the screen currently. Very important course. But in addition to this course that is currently available through us on coding proficiency, we will also be in the next month or so providing a course that is specifically designed for the clinical community and clinicians, so that you know that course should be out within the next 3 or 4 weeks, and we will be looking forward to announcing that and providing an additional webinar for clinicians at that time. The other piece that we are providing today through our sponsorship from Athena Health is a white paper on preparing your practice for the ICD-10 changeover. That link is available in front of you on the screen, but it will also come to you in the follow-up email, and will be linked to that email for your download, so you can automatically download that white paper from Athena Health. Thank you again, Lynn, for joining us for today's Learning Lunch. I'd also like to thank all of our attendees. Again, all registered attendees will receive an email with links to a survey, a quick 5-question survey, which will provide immediate access to both the recorded and PDF versions of this session. Completion of that quick survey will also enroll you in our monthly raffle drawing to win a new Google Chromebook. So please do take a few moments to participate. It's kind of a new thing we're trying out. In addition to supporting this live session, as I mentioned, there is a white paper available. Be sure to join us at Format Approved for our next Learning Lunch, which will air tomorrow, on avoiding red flags that might trigger a meaningful use audit, presented by industry expert Jim Tate. Thanks again, Lynn, and thanks to everybody for joining us, and we hope to see you at the next Learning Lunch.